This is the story of Fatima, a Somali woman raising her family in the United States. Before we meet Fatima, here's some background information to help you understand her world better. Somalis comprise the second largest group of refugees in the United States. In Somali culture, women like Fatima generally marry young, with up to 45% of women married by the time they are 18 years old. They value having children, and children are seen as gifts from God or Allah. On average, women in Somalia give birth to about 7.3 children. Female circumcision is common, and the type most commonly performed is the type 4, where the clitoris and labia minora are removed, and that the labia majora is sewn closed while leaving a small opening for urination and release of menstrual blood. Finally, prenatal care is a community-driven task. Neighbors and friends are midwives, and care is given in the home. Somali women in the United States experience higher rates of maternal and infant mortality. The Somali infant mortality rate and the maternity mortality rate are some of the highest in the United States, 120 per 1,000 live births and 1,200 per 100,000 live births, respectively. Additionally, a literature review by Fawcett et al. Found that Somali women are more likely to experience a wide range of perinatal complications, including emergency C-section, induction of labor, prolonged second-stage labor, postpartum hemorrhage, and perineal lacerations. Somali women are also up to 9 times more likely to experience delivery at or beyond 42 weeks. This puts them and their baby at increased risks of adverse sequelae like oligohydramnios, fetal distress, and C-section. So let's meet Fatima. Fatima is a 29-year-old G8P5 married to her husband Assad for 10 years. Together, they have 3 sons, 2 daughters, and a daughter on the way. They have also lost 2 children due to fetal complications. Her first child, a boy, died in utero 10 years ago at 26 weeks gestation. 4 months ago, her late-term 43 weeks gestation daughter died during delivery from respiratory distress. She is currently 35 weeks pregnant with another baby girl. Like many Somali women, Fatima believes that pregnancy is not a reason to seek medical care. She believes delivery is a natural process that does not require medical intervention. Simply put, pregnancy is an experience, not a sickness. Prenatal care in Somali culture differs from traditional Western practice, and Fatima trusts in God over science. She believes Somali women are met with unique challenges within the U.S. healthcare system, including language barriers, stigma from providers, and a general lack of control and modesty in the birth process. Breastfeeding is important and celebrated, but Somali women are taught that mental health issues like postpartum depression should be kept quiet. Other beliefs that Somali women include Western medicine relies too much on C-section and technology, a limited understanding of electronic fetal heart monitoring, or the process of limiting food and fluid intake during the birth process. Also, many women believe that if they have 1 C-section, they will need to deliver all subsequent children via C-section. Fatima practices childbearing rituals centered on faith and community. Somalis believe that home births and midwives are the standard of care, and mom should be the focus during pregnancy. Formula is commonly used to supplement breastfeeding due to the belief that babies cannot grow well solely on breast milk. C-sections are thought to harm the mother's health and future fertility. But in order to deliver vaginally, women must endure de-infibulation to reverse female circumcision. Somali women also commonly request episiotomies as they are believed to reduce tearing. In Fatima's culture, vitamins are considered unhealthy because they fatten up mom and baby. Mental health issues are taboo and commonly ignored. Women are told to keep their emotions and struggles private for fear of looking crazy. For example, Fatima was too ashamed to mention her sorrow after the loss of her 2 children. Touch from male physicians is discouraged unless it is an emergency. Somali women also feel privacy and modesty are not honored in traditional hospital settings. They are uncomfortable with how exposed they feel during invasive visits. For her perinatal care, Fatima wants only female staff to attend. Research shows that healthcare providers' lack of knowledge and understanding of differences in practice, beliefs and preferences, and expectations regarding pregnancy and childbirth are a barrier to improving refugee women's care in the U.S. The first challenge to care is language. Fatima speaks primarily Arabic with some basic English language knowledge. If healthcare providers do not provide interpreters or speak in a way that is easily understood, this results in confusion and frustration when communicating. Additionally, because women's responsibility culturally is to the home and to the children, it is important for nurses to consider the educational level of traditional Somali women, ensuring that everything is explained in a way that is easily understood. Finally, it is the responsibility of the nurse to provide appropriate educational material that is written in grade-level English and can be translated to Arabic. Fatima values modesty in her appearance. She traditionally wears a scarf around her head and covers her body head to toe in gowns. But when in an American hospital for childbirth, this is not often respected. Between vaginal exams, hospital gowns, and providers constantly coming in and out of her room, modesty is the last thing on anyone's mind. This causes added stress and anxiety for Fatima because it is not respecting her beliefs and values. This also applies to men, which can be her husband or male providers. Her husband and or male providers are not involved in the labor due to this value of modesty. The nurse must try their best to provide privacy for Fatima's comfort and think of options that adhere to her cultural preferences. An example of this is providing extra gowns or extra blankets for Fatima in case she wants additional cover-up when providers enter the room. Fatima exercises many childbearing beliefs and practices that are unfamiliar for American practitioners. Fatima has 5 children, which can seem like a lot for an American family. Additionally, her husband may have other wives, which can be a strange concept for traditional American families, but is an accepted practice in Muslim culture. In caring for Fatima, it is important not to let biases regarding her religion or other cultural practices hinder care, and it is imperative to let all providers know of her cultural preferences so they can behave similarly. Culturally, Fatima does not believe that C-sections are appropriate. Her beliefs are that whatever happens in the childbearing process are Allah's will and that Western medicine should not intervene. Additionally, Somali decision-making process can be very prolonged and left to males in the community. In case of an emergency, it is important for the nurse and healthcare team to know what her plans are for this birth, so not as to take measures that do not align with her faith. If a C-section is definite, it is important to explain that to Fatima so her community can decide what Allah's will is. This may take time, so the nurse must be patient, understanding, and respectful of the process. Like many Somali women, Fatima has fear of the unknown when it comes to medicine. In the past, she has felt judgment from her beliefs from hospital providers. This is why she may typically wait until she is critically ill to see the doctor. Fatima knows that her care team supports her when they use a proper interpreter to make communication and appropriate education a top priority. When the nurse uses effective communication teaching that relies to Fatima and her beliefs, then Fatima can feel reassured and comfortable to schedule more prenatal follow-ups without waiting until something is wrong with her or baby. Fatima has always used midwives for her previous pregnancy. This is a common practice in her culture. In addition, research shows that nurses working with a Somali doula resulted in better birth outcomes, with nurses reporting that they better understood Somali women and felt more confident in care. Understanding the importance of these services, Fatima was paired with a midwife and a Somali doula. She is happy that a midwife and doula can be part of her care. She is grateful that the staff will allow her to bring in her own traditional remedies in moderation, such as ginger, that will calm her during the labor process. She was told she can practice what she wants as long as it is not a danger to her or her baby. She is appreciative of the hospital and her care team. Fatima's providers respect her wishes of not wanting to do a C-section, but also told her why sometimes it is used and is necessary. After learning more about C-sections, Fatima was more open to discussion about it and understood that it is a sterile procedure, which she previously did not understand. There are other ways that Fatima's care team can support her. This includes building on Somali women's existing healthy habits, emphasizing breastfeeding and infant care, outside of using a doula, involving other Somali liaisons as educational assistants, and developing educational programming for staff on the implications of female genital cutting on the childbearing process. Fatima had a successful and positive experience with her care team. She wanted to thank them and show appreciation for their supportive attitudes of her culture and beliefs. She was able to fill out surveys regarding cultural competence and staff performance, as well as send positive reviews towards the staff that helped her through this amazing journey. It is the role of the nurse in the hospital to integrate her feedback in improving culturally competent care in the childbearing process. Thank you.